Welcome, class. This session is your entry point into the Year 4 Primary Care Family Medicine clerkship. This clerkship is not simply about seeing common conditions. It's about learning how to think like a first contact clinician who can integrate biomedical knowledge, biopsychosocial understanding, patient context, family dynamics, prevention, ethics, and continuity of care. I am Dr. Sharita Ramsaran, a family medicine and primary care physician, lecturer, and coordinator for this course. My expectation is that you approach this clerkship as an active clinical apprentice rather than a passive observer. Your first task is to shift your mindset from disease centered medicine to person centered primary care. In hospital medicine, the disease often takes center stage. In primary care, the patient, family, community, risk, resources, beliefs, and follow-up plan all matter. That's the professional lens we will begin building today. Before we define primary care formally, I want us to start with how patients actually experience care. In primary care, we are not just treating a condition, we are partnering with people over time. So I want you to think beyond the symptoms. What does this patient do for work? Who supports them at home? What do they eat? What stresses are shaping their health? What cultural beliefs, hobbies, routines, or fears may influence their decision? These are not extra details, they are clinical intelligence. The second issue is trust. Trust is one of our core deliverables in primary care. Patients disclose more, follow plans more reliably, and return earlier when they trust us. So ask yourself, what communication skill helps build trust quickly? Is it active listening, honesty, empathy, summarizing, checking understanding, or transparency? As you move through this clerkship, remember this: your clinical effectiveness will depend not only on what you know, but how well you connect that knowledge to the person in front of you. By the end of this session, you should be able to describe the basic elements of primary health care and primary care, discuss the characteristics of the good physician, outline the principles of family medicine, compare hospital care with primary care, identify members of the primary health care team, understand the burden of disease in primary care, and explain the clerkship format and assessment. These objectives are not here for memorization only. They are a roadmap for how you will function in clinic. You will be expected to apply these ideas when you take histories, present cases, write your casebook, participate in communication skills sessions, prepare for OSCEs, and sit your written examination. The goal is not to know what primary care is. The goal is to begin practicing like a thoughtful, safe, patient-centered primary care clinician. The World Health Organization's 1978 definition of primary health care gives us the foundation for this clerkship. Primary health care is described as essential health care based on practical, scientifically sound, and socially acceptable methods and technology. It must be universally accessible to individuals and families in the community with their full participation at a cost that the community and country can afford. That definition is powerful because it reminds us that healthcare is not only about advanced technology or specialist intervention. Good healthcare must be effective, acceptable, affordable, and reachable. In our Caribbean context, this matters deeply. A perfect guideline is not enough if the patient cannot afford the medication, understand the instructions, afford transport, or return for follow-up. Primary healthcare therefore forces us to think about equity, practicality, and community realities. The World Health Organization definition also reminds us that primary healthcare is an integral part of the country's health system and of the wider social and economic development of the community. It is the first level of contact between individuals, families, communities, and the national system. It brings healthcare as close as possible to where people live and work, and it forms the first element of a continuing healthcare process. So primary care is not a clinic location, it's a system level strategy. When a patient attends a health center for hypertension, diabetes, antenatal care, child health, depression, asthma, family planning, or screening, that encounter sits inside a larger social reality. Transport, work schedules, income, food availability, health literacy, family influences, and trust in the system all affect outcomes. This is why primary health care is broader than the doctor patient consultation. It connects clinical care to community life. Let us pause and think about the ecology of illness. In an average month, out of 1,000 people, how many do you think experience symptoms? How many actually see a doctor? And when they do seek care, which doctor do most people see first? These questions are important because they challenge the hospital centered view of medicine. Most illnesses begin in the community. Many symptoms never reach a hospital. Many conditions are self managed, discussed with family, treated at pharmacies, or presented first to a general practitioner or health center doctor. This is why primary care requires broad thinking. You will see early illnesses, vague symptoms, chronic diseases, psychosocial distress, prevention needs, and undifferentiated complaints. Your task is to manage uncertainty safely while identifying red flags and knowing when to escalate. The ecology of medical care shows us where illness actually lives. In a population, many people experience symptoms. Fewer consult a physician, fewer still attend emergency departments or hospitals, and only a very small number reach tertiary care. This means that the cases we see in hospital are not only the tip of the iceberg. Primary care manages the wider base of illness, common symptoms, chronic conditions, early presentations, prevention, mental health, family concerns, and social determinants. This changes how we think clinically. In primary care, not every symptom needs extensive investigation immediately, but every symptom requires safe reasoning. You must know the common causes, recognize red flags, use follow up appropriately, safety net clearly, and document well. Time, continuity, and review are often part of the diagnostic process. Primary care is the provision of integrated, accessible healthcare services by clinicians who are accountable for addressing the majority of personal health needs, developing a sustained partnership with patients, and practicing in the context of family and community. Let us unpack that. Integrated means care that is connected across problems, visits, providers, and time. Accessible means patients can reach care without unnecessary barriers. Accountability means clinicians are responsible for quality, ethical behavior, patient satisfaction, and efficient use of resources. The phrase majority of personal health needs is also important. Primary care physicians do not manage only one organ system. They receive the whole person. Physical symptoms, emotional distress, family problems, prevention needs, chronic disease, acute illness, and uncertainty. This is why primary care is both broad and intellectually demanding. So when a patient says, I am going to see my doctor, what are they really expecting? They expect access, they expect trust, they expect confidentiality, they expect someone who can listen, guide, explain, coordinate, reassure, treat, refer, and follow up. Primary care is therefore not only a service, it's a relationship based model of care. The primary care doctor often becomes the first contact clinician, coordinator, advocate, counselor, risk manager, and continuity figure. This means that your role is bigger than making a diagnosis. You must also understand what matters to the patient, what is realistic for them, and what system support they need. This is where family medicine becomes a practical expression of person centered care. Equity and access are not abstract ideas. They are everyday clinical responsibilities. Primary care should be affordable, easy to reach, user-friendly, available, and timely. But access is not the same for everyone. Age, gender, ethnicity, disability, social status, lifestyle, sexuality, stigma, health literacy, and income can all affect whether a person receives care. Health equity means giving everyone a fair opportunity to attain their full health potential. As future doctors, you must ask, who is being left behind? Is it the older adult who cannot travel? The working patient who cannot attend clinic during normal hours? The man who delays care because of cultural expectation? The adolescent afraid of confidentiality breaches? The patient with diabetes who understands the advice but cannot afford healthier food? Equity means identifying barriers and designing care around real lives. Let us think about the good physician. What words come to mind? Knowledgeable, kind, honest, patient, respectful, decisive, reliable, up to date. All of these matter, but in primary care, the good physician must be both clinically competent and relationally competent. Patients need to know medicine, but they also need us to communicate clearly, listen carefully, respect their preferences, recognize their fears, and advocate for their best interests. Clinical knowledge without trust may not lead to adherence. Kindness without competence may not lead to safe care. The good physician brings both together, sound science and humane practice. From the patient's perspective, a good physician demonstrates professional expertise, patience, attentiveness, honesty, up-to-date knowledge, respect for preference, and willingness to represent the patient's interests. These are not soft skills. They directly affect outcomes. When patients feel heard, they disclose more. When they understand the plan, they are more likely to follow it. When they trust their doctor, they are more likely to return for follow-up. When they feel respected, shared decision-making becomes possible. As students in clinic, you can begin practicing these behaviors immediately. Introduce yourselves clearly, ask permission, avoid interruption, summarize what you heard, explain your reasoning, check understanding, and show respect for the patient's story. This is how professionalism becomes visible. What is family medicine? Family medicine is an academic discipline with its own curriculum, research base, clinical methods, and professional identity. It functions at the primary care level and focuses on patient-centered care. Its aim is integrated, continuous, comprehensive care across the life course. Family medicine is sometimes called the specialty of generalism. That does not mean simple medicine. It means managing complexity across multiple domains: acute illnesses, chronic illnesses, prevention, mental health, family dynamics, ethics, uncertainty, and community realities. The subjective experience of illness is also central. Two patients may have the same disease but very different fears, expectations, support systems, and treatment barriers. A family physician must understand both the disease and the person living with it. McWinney's four principles give us a strong foundation for family medicine. First, family medicine is community based. We must understand the local population, common conditions, cultural context, and health system realities. Second, the family physician is a resource to a defined practice population. Responsibility extends beyond isolated encounters. Third, the family physician is a skilled clinician. This means managing common conditions, recognizing serious illness, coordinating care, applying evidence, and practicing prevention. Fourth, the patient-physician relationship is central. In family medicine, the relationship itself becomes therapeutic. Continuity, trust, respect, and shared understanding improve care over time. These principles should guide how you observe, think, write, and present during the clerkship. The patient-centered consultation means exploring both the disease and the illness experience. The disease agenda includes symptoms, signs, history, examination, investigations, differential diagnosis, and management. The illness agenda asks about the patient's feelings, fears, ideas, expectations, and impact of the illness on daily life. This is where 5 becomes useful: feelings, ideas, functions, and expectations. A patient-centered consultation also involves understanding the whole person, finding common ground, strengthening the doctor-patient relationship, incorporating prevention and health promotion, and being realistic about time, resources, and the patient's capacity. The ultimate goal is a mutual decision. The clinical encounter is not a lecture, it's a negotiation between doctor and patient, guided by evidence, context, and trust. Primary care manages a wide burden of disease. You will see diabetes, hypertension, cardiovascular disease, respiratory complaints, gastrointestinal complaints, women's health issues, musculoskeletal pain, skin conditions, and mental health concerns. Mental health deserves special attention because it does not always present as I am depressed or I am anxious. It can present as stress, body pains, poor sleep, fatigue, headache, poor diabetes control, repeated visits, or vague symptoms. So you must develop a high index of suspicion. Do not dismiss physical symptoms, but do not ignore psychosocial contributors either. Good primary care integrates both. It asks, what is the diagnosis? What is the risk? What is the patient experiencing? And what is driving this pattern? With regards to the distribution of disease in primary care, a large proportion of illness is self-limiting. These may include many upper respiratory tract infections, gastrointestinal complaints, musculoskeletal problems, and skin conditions. Another important proportion involves chronic diseases such as asthma, hypertension, diabetes, ischemic heart disease, and thyroid disease. These require continuity, monitoring, lifestyle support, medication adherence, and complication prevention. A smaller but critical proportion is the life-threatening acute myocardial infarction, strokes, acute abdomen, severe depression, serious infection, and other conditions. The primary care challenge is balancing safety with proportionate care. We must avoid over-medicalization every minor illness, but we must also avoid missing dangerous disease. That is why red flags, risk stratification, safety netting, follow-up, and documentation are core primary care skills. Now let us move from concepts to the structure of the clerkship. This clerkship includes face-to-face, recorded and online lectures, general practice clinic exposure with a minimum of 25 hours, group presentations, the family study, an individual evidence-based medicine assignment, communication skills sessions, and one academic clinic at the St. Joseph Health Center under family medicine supervision. Each component has a purpose. Lectures build conceptual knowledge, clinics build observation, communication, and clinical reasoning. Presentation builds synthesis and peer teaching. The family study builds understanding of social context. The evidence-based medicine assignment builds evidence use. Communication skills sessions build professional interaction. Academic clinics build supervised clinical application. Your responsibility is to engage actively and document your progress from the start. My Learning is the operational hub for this clerkship. You will find the course material, course outline, academic honesty declaration, lecture material, assignment guidelines, upload portals, casebook instructions, grades, and learning resources there. Please do not rely only on WhatsApp messages or informal updates from classmates. Professional practice begins with reading official instructions, checking deadlines, and submitting work correctly. Before asking a procedural question, first check whether the answer is already posted on My Learning. This is not just administrative, it is part of professional accountability. In clinical practice, missed instructions and poor documentation can compromise patient care. In the clerkship, they compromise your performance and reliability. The sexual dysfunction presentation will be done in 4 groups: erectile dysfunction, premature ejaculation, decreased libido, and orgasmic difficulties in women. These topics require clinical maturity and respectful communication. Your presentation should not simply define the condition, it should show how a primary care doctor approaches the consultation. That includes relevant history, common causes, biopsychosocial contributors, medication causes, relationship factors, mental health considerations, examination, investigations, counseling, treatment options, red flags, and referral criteria. Be respectful, non-judgmental, culturally sensitive, and evidence-based. Sexual health is often under-discussed because patients feel embarrassed or there's a stigma attached to it. A good primary care doctor creates a safe space for disclosure. The acute presentation topics are chest pain, headache, dizziness, and back pain. These are high-yield primary care presentations because they can range from benign to life-threatening. Your task is not to produce an emergency department-style list of every possible diagnosis. Your task is to demonstrate primary care reasoning, first contact assessment, red flags, risk stratification, focused history, focused examination, initial management, safety netting, follow-up, and referral threshold. For example, back pain is often mechanical, but you must recognize red flags for malignancy, infection, cauda equina syndrome, or fracture. Headaches are often benign, but you must recognize sudden onset, neurological deficits, meningism, or raised intracranial pressure. This is where judgment under uncertainty becomes critical. The family study helps you to understand illness in context. You will work with social cases provided through Ms. Devika Baburamji's. Your task is not to judge the family or intrude into private life. Your task is to understand how family structure, caregiving, income, housing, health belief, diet, social support, and access to care shape health outcomes. Many patients do not make health decisions alone. Families influence diet, medication adherence, clinical attendance, caregiving, finances, and beliefs about illnesses. This activity links directly to patient-centered care and social determinants of health. It also helps you see the physician's role as an advocate, coordinator, educator, and a system navigator. The evidence-based medicine assignment will be posted on My Learning and completed individually. Evidence-based medicine is not simply finding a guideline online. It is the disciplined integration of the best available evidence, clinical expertise, and patient value. You should be able to frame a focused clinical question, identify credible sources, appraise the quality and relevance of the evidence, and apply the findings to a realistic primary care scenario. This matters because patients rarely present exactly like textbook cases. Guidelines support decision making, but they must be interpreted in context. Comorbidities, affordability, availability, patient preference, and local health system realities. Your EBM work should therefore be accurate, referenced, practical, and ethically grounded. Your assessment in the clerkship outlines how your performance will be assessed. The final assessment is worth 80%. The written examination consists of 40 MCQs and is worth 40%. The OSCE is also worth 40%. You must pass both the written examination and the OSCE to pass the clerkship. Continuous assessment is worth 20%. This includes 4 course assignments, the casebook, the oral casebook review, and attendance requirements. The casebook includes 4 long medical cases and 1 ethical case. The oral casebook review allows you to defend your clinical reasoning, management decision, ethical thinking, and reflections. Attendance expectation includes 75% of class attendance, a minimum of 25 clinic hours, and 1 outreach activity. Start early. Track your requirements. Do not wait until the end of the clerkship to organize your casebook or clarify expectations. The group presentation rubric is not only a marking sheet, it's a performance guide. You will be assessed on originality, organization, accuracy, engaging delivery, visual aids, peer assessment, ability to answer questions, time management, references, and presenter skills. Organization and accuracy carry major weight. This means your presentation must have a logical flow, avoid repetition, use current reputable sources, and stay clinically relevant. A strong presentation should engage the class. Use cases, role play, discussion prompts, short questions, or practical consultation frameworks. Avoid reading from slides. Slides should support your message, not replace your thinking. Time management also matters. In real clinical and academic settings, the ability to communicate clearly within time is a professional skill. I'd like you to note that professionalism begins now, not after graduation. You are to dress professionally for clinics, arrive on time, submit assignments by the deadline, log in early for online sessions, review lectures before class and before question and answer sessions. These behaviors are not small details. They build your professional identity. A doctor who is late, unprepared, careless with instructions, or dismissive of expectations can compromise patient safety and team trust. The same habits you practice as a student will follow you into clinical practice. So treat this clerkship as a rehearse for real responsibility. Be prepared, respectful, accountable, and engaged. At this point, I'd like you to invite questions. You can email me questions, but I'd also like you to ask yourself what part of this clerkship feels most challenging. Is it presenting cases, speaking with patients, writing the casebook, applying evidence, managing uncertainty? Clarity is part of preparation, and preparation is part of professionalism. As we close, I want you to see family medicine as a disciplined, intellectually demanding, and deeply human area of medicine. It requires you to combine science with context, evidence with empathy, and clinical reasoning with practical judgment. During this clerkship, be curious, listen to patients, observe how doctors manage uncertainty, pay attention to family dynamics, prevention, ethics, communication, and continuity. Reflect on what you see. Primary care is where medicine meets real life. Patients come with symptoms, stories, constraints, beliefs, fears, responsibilities, and hopes. Your role is to learn how to meet them with competency, respect, and clinical wisdom. I wish you a productive and meaningful clerkship experience.